Thank you so much. I'd like to start by acknowledging that we stand on Aboriginal land today, and I'd like to acknowledge the traditional custodians and owners of the land and all of my Aboriginal colleagues here today. I've prepared an update of the outreach program. I'll try not to go too long, so I leave time for questions at the end, and take you through. No, I do have a pointer. We'll go through a game. At first, this is very much an interactive session. The idea is that it's a conversation. It's not going to be a didactic thing where somebody stands at a lectern and you all are educated. We really want this to be a conversation. It's a two-way street, and the game will start that off. There are prizes at the end, and you've got to be in it to win it. Most people are asked to turn the phones off during conferences, but I'd actually like you to turn your phones on and log into a little website to play the game. After that, we'll go into why we do outreach, what the program's achieved so far, what we should do next. We've got 3 years of program funding, so that's a big opportunity for us and you, and a little bit of introduction to the workshop session that will occur this afternoon. So can I ask you to please go to kahoot.it. Thank you all for playing. I hope you found that interesting. And I wouldn't expect you to know the answers to some of those questions. It's really just to get the conversation going and to get you thinking about some of the things we'll talk about today. For the passionate RDN staff that played, you do have inside information, so you can't win, unfortunately. But can Smokey, Jane, and the runner-up please come and get your prize? Done.
Thank you, Sharif.
You're Smokey?
I'm Smokey. So, why outreach? A lot of you have been involved in the outreach program for a long time. Some of you have been going out and visiting rural communities for 10 years or more. Others of you have been administering outreach services for longer than that as well. So I think we all know why we do outreach, and it really is to improve access to health services for rural communities and Aboriginal people all across the state and the ACT. But the things that we do try to remove are the access barriers to accessing services. And those are distance and disruption, obviously, for our rural and remote communities, cost and economic hurdles that a patient might encounter when trying to travel to an urban location to access a service, or there might be a fee charge for that service, so we try to remove those barriers as well. And some services are more culturally safe than others, as it's a really important part of our program to ensure that the services that are delivered are culturally safe. There'll be a session on that today. And importantly, to strengthen the capacity of local services to continue to support and manage patients' health care. And that's a really important part of the program. That's often the flow-on effect rather than the day-to-day direct patient interactions. But by working with local clinicians, you do transfer some of those skills, and there's lots of anecdotal evidence of that. A lot of you do report some upskilling activity, but we feel that really underrepresents what's actually happening in terms of the capacity that's being strengthened and the skills that are being transferred. And I would argue it's two-way learning as well. A lot of clinicians, and the feedback that you have and that you provide in your surveys is how much you gain and learn from working in different environments and working with rural communities and Aboriginal communities. So I won't dwell on this, but it's important to acknowledge that this program is funded by the Federal Department of Health. I noticed on the question there was mixed views about that, so I will clarify, yes, it is absolutely the Department of Health. And it's under these 4 programs. I won't get into all of the acronyms. But they are essentially designed to improve access. Sorry, it's 5 programs, that's right. They are designed to improve access to health services, medical specialist services, allied health and nursing services for Aboriginal communities and rural communities. Some have a particular focus, like the MOI-CDP program, which focuses on chronic disease in Aboriginal communities. It also supports services in rural, urban areas. There's the Healthy Ears program that supports access to hearing services for young Aboriginal people. The Visiting Optometrist scheme that supports increased access to optometrists, and the Aboriginal Eye Health Coordination project, which doesn't deliver services itself, but is very important and quite new in coordinating existing services, including outreach services, to ensure that there is a continuous and accessible eye health pathway for Aboriginal people anywhere in New South Wales. It is a national program, but we're talking about New South Wales and the ACT today. But we are joined by some of our colleagues from Victoria and Queensland who deliver the program there. So thanks so much for supporting us and being here today. We're often asked, well, how do you decide where your services go? You've got this finite bucket of money. How do you distribute this and the resources in the best way possible to achieve health outcomes, improve health outcomes, and improve access? And that is, it is a simple methodology that we've followed and we have for a number of years. We do improve it and tweak it. But ultimately, we work with local partners to identify needs. That is the cornerstone of what we do. So we have partnerships with Aboriginal community-controlled health services, local health districts, PHNs, other types of service providers who work in local communities and we feel have the best knowledge of what those communities need. And we do our best to work with them to deliver those services. We take all of those needs and we weigh them up and validate them against some objective data around populations, any burden of disease data that might be available, although it's not always available at that granular level. More often than not, it's not available. Socioeconomic information, and that helps us to prioritize where the services go. And then very importantly, we look at where existing services are. We do not want to duplicate existing services. That doesn't mean we won't put in a endocrinology service where there might be an endocrinology service already, but we would look at whether that endocrinology service is accessible, and if it's not for any reason, we would try to make it accessible by expanding it in some way, or we'd bring in another service to ensure that that community has equitable access to that service. Other considerations for supporting a service is, are they value for money? We've sort of refined how we measure value for money. And I'll go through that in a minute. We look at the available workforce. There's a pragmatic element to it as well. We might know there's a need, but we might have tried for a very, very long time to fill a particular service, and we decide to go to the next highest priority if we aren't going to be successful in delivering that service. And then very importantly, all of the visiting services we realize work as part of a much bigger system of health services and communities, where outreach is a very, very small part of the whole health system and what communities deal with every day. So it's imperative that they are integrated with local GPs, Aboriginal health workers, other types of services to make sure that there's a patient-focused pathway and care, which is what we'll strive to do, and there will be a workshop discussion on that this afternoon. Equity is a really important part of planning as well. So we don't use a population formula to distribute money to a particular geography. It really is needs-driven. But that does demonstrate equity. For those of you that are familiar with the modified Monash model, it's a geographic classification model that classifies areas into remoteness categories. So RA1 is where we are today, very not remote. And the most remote areas are your MMM 6 and 7. And you can see per 1,000 population in those areas, the number of clinic hours that are being delivered in those areas is much significantly higher than in the more urban areas, and we feel that's appropriate. We feel that that's responding to the absence of other types of services or alternatives that those communities would have. But that's something that's continually being reviewed, but that comes out. We're not targeting a particular distribution, but that is what comes out. So speaking of local partnerships, they are really the cornerstone of our program. And this is a picture of the team at the Glen and a regional meeting we had in April, I believe, where we worked with all of the stakeholders in the area, which was the PHN, the local health district, the Yarra Aboriginal Community Controlled Health Service, and the Glen itself, which is a community-controlled residential rehab service that hosted the service, and some of the residents that came out to give us a tour of the place as well. Those are 6 monthly meetings, and they help inform what we do with the outreach resources for the following year and to refine them halfway through the year as well. And there is some data and sophistication that goes on behind that as well, but that conversation regionally and regularly is what shapes the program. And ultimately, these communities own the services that they deliver. Our view is that we are just facilitators to make sure that happens. So this is a little bit of a network map or a diagram flowchart of the program and how it's structured. It's a bit of a hybrid of some centralized coordination that we here and our outreach team provide. I mean, there are people with white shirts on, but we call ourselves the outreach team. But like Rose said, I believe everyone in this room is part of the outreach team. In fact, we're about 1/10 of the outreach team. There's more than 800 or almost 900 health practitioners visiting communities in rural New South Wales, and about 200 administrators, right from people in the department that make decisions about the way services are delivered or funding is allocated, and cascading all the way down to people that administer payments to specialists or arrange rooms, book patients. It's at least 1,200 people. So we would probably need a stadium if we were going to have the whole team. But thank you for being part of the smaller team today. So ultimately, we try to focus on, doesn't point very well, on the left side, we try to focus on patients and communities ultimately and what they need, and then finding the health practitioners to deliver those services. Those health practitioners are primarily contracted to our local partners, which are either an AMS or local health district or another type of service provider organization. And those regional meetings are designed to coordinate those three local partners because they often will all work in one geography. Typically, you'll have a few AMSs, one LHD, one PHN, and potentially some other types of providers in any geography that will locally plan services. And then we have a statewide view, so we can move pieces, and we do move resources in and out of regions in response to needs as needs change. It's very, very important to remember that the outreach program is a gap-filling program. So we necessarily have to be quite dynamic and nimble and move resources in and out because of the changing environment. And from my observation over a few years in this program, I would say that environment is changing more quickly and more often. And I would say that has a lot to do with commissioning and other types of changes that are happening with other funding bodies. But gaps close and are created when all that activity happens, and we've got all the more reason for us to have really good systems to identify that with local knowledge and be able to respond as quickly as possible. Importantly, there is a governance structure in this program. So we've got the working group, which is made up of our representatives from our local partners, so our ACHs, PHNs, and LHDs, that review all of our plans and the way our strategy. There's an advisory forum group as well that's chaired by the Department of Health that has stakeholders on representing specialist colleges, the Ministry of Health, quite high-level state bodies. The department itself approves and signs off on actual plans. They were submitted last week, thankfully. So we've already got our 17-18 plan laid out potentially. And the little group on the top right-hand corner is a newly formed Aboriginal Eye Health Advisory Group, which is part of the Eye Health Coordination project that consists of eye health stakeholders, and has so far done very well. So what has the program achieved? I'm going to show you a few stats, and if you're a nerd, you might enjoy them. If you're not, please bear with me. We have outreach services in about 165 rural communities across New South Wales and the ACT. Some communities might have one service, another community might have 20. It's not an even distribution. And the symbology is different types of programs and providers. If you want to know more, I will make this presentation available, so you can go and have a look at our website to see where all the services are if you don't know where that is already. These are the types of services that are going to be funded, are funded in the current plan and will be quite similar next year. This is the distribution, we'll go back to medical. This is the distribution of our medical services. So there's more than 25, 30 disciplines of medical specialists, and those include super subspecialist categories, different types of pediatricians and surgeons. If the list would get too long and be impossible to fit on the slide if we did that, so we've just aggregated them up into different categories. But as you saw in the Kahoot question, GPs are our most frequently requested service out of the medical specialists, psychiatrists and pediatricians, and that's always been the case
since I've been involved in this program. I think that's telling of some of the gaps in our rural communities. I'll let you study that later. And then we've got our allied health and nursing services. Sorry, there's a bit of a lag. Aboriginal health workers, you can see, are right on the top of the list, followed by nurses. Those two types of providers are real cornerstones of almost any service that we provide, particularly into an Aboriginal community. Any multidisciplinary outreach team that might involve an endocrinologist and a dietitian and a podiatrist needs an Aboriginal health worker to pull it all together and to coordinate patients and support their access through that service. So that's probably going to be a continuing feature of our program and a very important one. Again, I'll let you look at this later, but it's quite a wide range of allied health providers involved in the program as well. So we've grown quite significantly over the last 4 years. Outreach is more than, it's almost 15 years old now, but we just, to make it meaningful, we measure from 2013, which is the current funding cycle that's just about to end in 3 weeks' time. We've more than doubled all of those indicators in the last 4 years, with largely the same resources available, actually. So that's clinic hours. You can see the purple line. That's really a standard measure of access, we think, because different services will have different types of throughputs. The dermatologist will see a patient every 10-15 minutes, whereas a psychiatrist would take 45 minutes or maybe an hour. So patient throughput's not the most standardized way to measure access. And then on the columns, you can see that is absolute patient access. It is one patient every 3 minutes. So by the end of today, today there's probably about 70 clinics occurring. By the end of today, 700 patients will have accessed the program, and 415 of them would have been Aboriginal. So it is a very large program. It is moving very quickly, and you are all part of that delivery mechanism that makes it a reality on the ground. So people that couldn't be here today are probably doing clinics somewhere. And we're particularly pleased that the Aboriginal patient access is so high and has sort of incrementally grown over the years as a percentage of total patients, and that's because a lot of the newer programs, like the Healthy Years program and an expansion of the VOS program, have been focused on Aboriginal people, and it's good to see that the uptake from the Aboriginal community is there. And I have to attribute the success of that program, or any of the Aboriginal programs, to the Aboriginal community-controlled health services that host the majority of them. We would not have the uptake, we would not have the interaction or the engagement of those communities without them being hosted and controlled and managed and owned by the Aboriginal community-controlled health services. So I think that partnership has been integral for this program. This is the number of services. There's more than 1,200 now. I mean, that number fluctuates, and the way we count services changes, but you can see it's gradually increased. What's important is probably the light green line, where all the services are actually operational now. Like, it's probably can't get much better than 95, 97, but say for the last 18 months, the last year and a half, all of the programs have been fully operational. They're spending all of the resources, which is excellent. It also means that there aren't any resources left to fund new services, so that proposes a challenge at the same time. The little orange line on the bottom is the number of services that have reported upskilling, and there's a gradually increasing trend there as well, and we would like to find ways to support that more. We think that's a really important part of the program. I know it's often difficult to spare time in your clinic to do formalized upskilling. We know it happens informally anyway, but if there were any opportunities you had to deliver upskilling as part of your clinics, we would like to support that, because we think it's a really important part of this program. This is a little update on the Aboriginal Eye Health Project. It's a fairly new program, and its 3 KPIs are really to develop partnerships, and that's been done in most New South Wales regions. Gaps and barriers have been identified in most of those New South Wales regions, and some solutions have already started to be implemented, but this is an ongoing program, and it's been just almost finishing 12 months now. And I think it's a really important part. Again, it doesn't deliver services. It's designed to coordinate services that are already there, and improve systems to improve access to eye health services. If you want to know more about that, talk to Claire or Eliza. So how did the program grow? This is where it gets a little bit nerdy, and I'll skip some slides if I start to lose you. this shows essentially what we've spoken about already in terms of significant increases in Aboriginal patients accessing the program and clinic hours and patients. There's one patient every 3 minutes. There's increased the number of towns that access services. That's excellent. But I think importantly, the solid black line is the costs per clinic hour. So every quarterly cycle where you very dutifully collect your clinic data and provide it to your AMS or your subcontractor provides it to us, we use that information to refine the way services are delivered and to make them more cost-effective as well. So a more cost-effective service may not sound like good news to everyone, but what it does is it allows us to reinvest that money into new services, and there's some excellent examples of some newer Aboriginal community control health services in the scheme of things that weren't around when the program commenced, say, 7 years ago, but are in a position now to roll out their own services, and we've been able to utilize those resources to actually seed fund some of their programs and to actually deliver services. So that constant churn allows new needs to be responded to. Anyway, we've reduced the cost of delivering the service by about 7% annually each year, and that's despite obvious increases in rates that occur as part of normal inflation. And that's a collective effort. We've all worked very hard to achieve that and to make sure we utilize all the resources and that they're reinvested to support priority needs. This is, I get excited about this stuff. So this is the distribution of our Aboriginal, our allied health and nurse and Aboriginal health services in terms of cost per clinic hour. So we're always watching this and we're looking at for the outliers. So the average cost is about $86 per clinic hour. So if we see services that cost $250 an hour in that category, we examine them and see, do they really need to cost that much? Should we do something differently? I mean, there's a lot of sort of rhetoric around efficiency and improving services and all that, but nobody really can give you a manual and says that this is a cost-effective services and this is not a cost-effective services. But we have enough services within the program to benchmark them against themselves in the New South Wales environment. And we break that down into MMM categories and different types of health disciplines. But this is a particularly useful tool that we started about 3 or 4 years ago, and that's you can see the effect of that. It does translate to improved access. We've doubled the number of patients accessing this program, and this has contributed significantly to that. No, it doesn't. So part of being more cost efficient is transferring some of the cost to Medicare. So we do, yeah, that's one of the tactics is to draw down on some Medicare so we can free up program money, if that is a possibility, and we'd like to do that ever more if that's available. We know some new Medicare items are coming out for different things. There's a new Medicare optometry item, for example, for telehealth. There's GP Medicare items coming out for the diabetic retinopathy scan. So we're watching that space very closely and try to adapt services to draw as much down from Medicare as possible. But not all practitioners can claim Medicare. And I'm getting the 5-minute signal. So I will skip that one. So what's next? There's quite a few opportunities. We've been given funding for most of the programs for the next 3 years. We think that's a real opportunity to strategically look at the program and the needs and to look at the environment and how it might change and work with our local partners to actually plot out what these programs do over the next 3 years. We have very strong partnerships, and I think all of what we're seeing today is evidence of that. Through those partnerships, we have fantastic local knowledge that we think is a real opportunity and one of the sort of most valuable assets that we have, and planning expertise. There's a lot of interest and capacity in telehealth, so we think outreach naturally lends itself to telehealth. The structure is already there typically for a service. If we can introduce a telehealth element, it wouldn't cost very much or not much at all because it's remunerated by Medicare, but it would improve access even further. And we have a committed outreach workforce. This is the outcome of a recent survey that most or some of you would have completed in the last few months. About 80% of health practitioners expect to or intend to continue delivering outreach for the next 3 years or more. So that's good longevity, and it kind of nicely fits in with the 3 years of funding that we have. So I think there's a lot of things lining up for this program. There are some challenges, which might be opportunities as well, is that, like I said, the program's fully allocated. If a new service is to come on, we generally have to find a way to make another service sustainable or pass it on to something else. And I think those regional coordination discussions are more and more important for that reason. And coordination with PHN commissioning activity, LHD initiatives, other types of initiatives, I think that's going to be very important. And while I do say the program is fully allocated, we do see a lot of transition throughout the year, and in 12 months, 24 months, 3 years' time, we'll probably have quite a different looking program. And I would like to think that's because we remain adaptive to our environment. Ensuring, so 250 new needs have been identified through our needs assessment process. So we can't, at this stage, support those needs with our program, but again, we would like to work with our partners to find ways to do that. Ensuring outreach services are improving health outcomes. All the things I've showed you today demonstrate access. They don't really demonstrate health outcomes. The underlying assumption of this program is that if you have access to a health service, that you will be healthier. I think it depends. I think some communities or some patients or some services are more effective than others. I think we would like to understand which ones those are and how we can improve our other services, and there will be a workshop topic about that today. And providing a patient-centered service. Patient-centered is one of those words that gets thrown around a lot, but I do think it has real relevance to this program. Warren's here today. I always use this photo. It looks like a lovely clinic in Port Macquarie. It is, but there's a lot going on to pull this together. There's a GP that comes from Warren AMS. There's a student from Western Sydney University. The Aboriginal health worker, Laurie Clay, on the right, coordinates referrals from 2 different AMSs. The ENT comes from Westmead to do low-risk ENT surgeries. High-risk ENT surgeries are referred to a resident ENT surgeon that goes on a separate list. And there are others. That's just to get things started. It's very complicated to deliver a service like an ENT surgical service in a clinically safe and coordinated way that focuses on the patient and ensures that they have a smooth pathway to all the different elements of the service. There are audiologists and audiometrists involved in this program, as well as speech pathologists. So I just couldn't get them all in one room at the same time. That's the coordination challenge, and I think it's going to be exacerbated by all this other change in the commissioning and the changes of services. Some new services are coming on and some are coming off. All right, well, thank you very much, and enjoy the rest of the day.